Hi ladies, I'm Cindy. I'm Dr. Ghurani's pre-op coordinator from Body, and we're gonna do live video today with the doctor here, answering a couple of questions that you guys posted over the past few days. Okay, doctor.
Hi.
The first question is, can you breastfeed after a BBL?
Okay, that's a good question. Welcome to Body Aesthetic Center. Breastfeeding after surgery is obviously, the answer would be immediately after surgery, please pump and dump. There's going to be medications on board from anesthesia, pain medications, antibiotics, and I don't want your child or newborn to have that type of stuff running through their system. Usually after a pregnancy, we would like to wait 6 months before you have a BBL. And usually a lot of patients are done breastfeeding by that time, but I'm not discouraging you from breastfeeding, so please go ahead and continue breastfeeding as much as you want to or can, but definitely around the time of surgery or immediately after surgery, please pump and dump until you're done taking all the medications. So I would say at least 10 days of pumping and dumping, and that should be okay. But anyway, always consult with us and we can guide you each patient specifically.
Okay. The next question is, what are your requirements for a mommy makeover?
Okay. The requirements for a mommy makeover, there's different types of mommy makeovers. There's a mommy makeover which includes just a straightforward breast augmentation. So somebody that has is complaining about a small size, but their nipples have not dropped below the fold. And loose skin in the abdominal area, which due to pregnancy or weight gain and weight loss has not retracted or has not shrunken down to the point where the patient is satisfied. So I'm sure you're going to want to ask, or ladies are asking about the weight requirement. And the reason I do ask patients to lose weight, and again, please do not worry about the BMI, because the BMI is a very arbitrary number. It doesn't take into account the fat distribution. So my main thing is to differentiate between specifically for the tummy tuck part, patients need to understand that a tummy tuck really is meant to remove extra skin that has folded over and caused a little pooch, and it's not going to go away when, for example, we do lipo. The patient's skin is not going to shrink enough to be flat enough for them to be happy. So that's when I try to get them to understand that it's a skin surgery, and that's what the tummy tuck will achieve for you. It's not going to give you that much improvement in contour. That means from the side, the skin is going to be flat, but it still remains thick because there's still fat there. And from the sides, the flanks, we do only a limited amount of lipo. It's about 1,000 cc's, so we split 500 for each waistline area, and that's not going to give you that much of a contour. So losing weight will help you achieve a better outcome with a mommy makeover. I think the most ideal situation is to let us decide if we go ahead with the liposuction first to give you the shape, and then go ahead and take care of the loose skin. And that's something that I have to do by looking at your pictures or having you in person for a consultation. But this is a very broad topic, and this is a very limited time online. So basically the requirements vary, but I really, for the mommy makeover, I would like to see less weight in the front, visceral fat, which is the fat internally, be less dominant, because what happens is, I'm sure as everybody online wants to look flat, wants to have a nice shape, and that visceral fat comes in the way, and yes, we can remove the skin, but it's not going to give you that nice flat shape that everybody's looking for. So I don't know if I really answered the specific requirements, but what I was trying to just put them into two different categories and explain to patients what a tummy tuck can achieve for you and what lipo can do for you. And I might be going off script because we were talking about mommy makeovers, but I think the body contouring topic is important so that we can make patients kind of understand why sometimes we suggest to go one direction or the other. In terms, going back to the breast, I'm kind of jumping back and forth, but going back to the breast, there's the ladies that require an augmentation because their nipple's in the right place still, and then there are the ladies that need a straightforward breast reduction because their breasts have, the nipple has gone down and the breast is large and it bothers them. And And there's also the breast that has lost volume, but also the nipple has dropped and is pointing more inferiorly. So the ladies with a large breast need a reduction, a formal reduction, and that still can be combined in a mommy makeover. And the ladies that have a deflation or loss of volume, and again the nipple has gone down, that is a lift, inverted T lift with an implant. And again, when we do our measurements and we see pictures, and please send us pictures that are, at the level of the breast, showing the shoulders to the knees, so that we can give you an honest opinion online. And we always welcome them to come in, so I can give them a little bit more detailed, tailored consultation to help them with their specific needs. And don't be surprised that there's times where we're going to suggest one procedure first, and then yes, another procedure. Like I say to all my patients, the cliche statement: this is a journey, not a destination. So there's multiple procedures that need to be done to restore that youthful look that you might be looking for.
Okay. Now, the most asked questions for the past 2 days, it's what is the difference between breast implant under the muscle and over the muscle?
Okay. I think if the patient is in standing without animation or taking a picture, a lot of times you can't even tell. Okay. My personal preference is I don't like to damage the muscle, because I think the pectoralis muscle is a very important muscle. I don't feel like any of the implants will ever remain completely under the muscle. They're really not submuscular, they're partially submuscular. The muscle sits above, on the top half of the implant, because the nipple on the female particularly sits lower than the pectoralis muscle. So I feel like the biggest issue I've seen with them is when a patient is moving around and contracting their muscle, the implant animates. By animates, I mean it moves. They have a tendency to move to the side. So there's, over time, I think they start out really nice, both of them, but over time the ones under the muscle get pushed down to the side. So I don't like that look. I would like, Dr. Payne, go ahead, come on in, no worries. We have a live, but that's no big deal.
It's fine.
So, excuse the interruption, but we're a busy clinic here. So, going back to my preferences, I think that the implant under the muscle can also make the cleavage that everybody wants look a little wider, because as the muscle contracts from the midline towards the arm, that cleavage is going to be pressed down. Okay, so in my opinion, and that's just my preference, I'm sure there's a lot of other doctors that might disagree. I think that if you have a good pinch test, that means a good 2 centimeters of tissue that I can pinch between my fingers on the upper pole, we're not going to have an issue hiding that silicone implant. I think that the silicone implants, the 5th generation silicone implants, are very natural feeling, so I don't think we need to hide it that much. Okay, some people will throw the argument out that under the muscle will hide the implant better. I don't disagree, but I think the majority of patients that I choose to go above the muscle don't have that issue, because we have enough tissue to cover the implant. Like I said, 2 centimeters of tissue above there, and so I see that I get better cleavage, and I eliminate the animation, the implant actually moving when the patient is active, and that for me prevents it from moving to the side and dropping. When you go into the muscle, I think you're helping gravity. And one note that I've noticed from my own personal surgical experience is that it doesn't matter how good the surgeon is that has done the implants. Eventually, when you go back in to exchange them, or if something happens to the implant, I've always noted that the muscle kind of window shades or retracts upwards, and the implant is no longer submuscular. It's actually completely under the breast tissue, and it causes actually more droopage. So almost 10 years ago, I stopped doing it because I didn't see the benefit, risk versus benefit. The studies that came out, and they're very respectable studies, they're randomized control studies, that say that there's a little bit more increased chance of a capsular contracture. That means the capsule around the implant forms and becomes thick and can be symptomatic if you go above the muscle. But again, my argument against that, or to kind of like be the devil's advocate, if the implant is sitting mostly under the breast tissue, even though you put it partially under the muscle, what's to prevent it from forming the capsule? So, and eventually it ends up under the breast tissue anyway. So long story short, in my opinion and my personal preference is to just go straight under the breast tissue. I try not to go through the breast tissue at all. I try to go under it. There is a separation, the fascia, the covering of the muscle, I lift that up and I sit right on top of the muscle, okay? And that also prevents me from going through the tissue that makes milk, the lactiferous tissue, and I think that's a cleaner procedure. Okay? I hope that helps everybody think about the answer.
And the last question for today is, will inner thigh lipo make my thighs skinny?
Very good question, because I ask a lot of, I ask my pre-op coordinator to ask a lot of the patients that come in after a first BBL to give me inner thighs, and they feel like it's going to make them look thin, and I actually disagree with that. What I try to go for is the fat in the upper inner thigh to achieve as much as possible a thigh gap, which is very desirable look, and improve the contour of the inner thighs very high up, where as we gain weight, there's fat deposits very close to the groin area, and I think that is a little bit unattractive. And if we can smoothen out that area and make it turn in better, as opposed to look bunched up and more over contoured, I think it looks more attractive in clothes, in jeans, or in a swimsuit. And it gives me a fresh, untouched, unscarred fat that I can use to help the patient. Otherwise, when ladies are so skinny that we're really trying to look for as much as we can, I have gone as far as suggesting it, but again, I'm very aware that most people don't want to have thin thighs. And going inner thigh, you guys are ignoring that there's also the anterior thigh and the lateral thighs, and that inner thigh lipo will not make your thigh look that thin or small. What I try to do is I try to make the contour from the top of the inner thigh towards the knee look more uniform and pleasing to the eye. And my idea is not to aggressively remove that much fat to the point where I actually cause a defect. I just need a good amount of substantially virgin fat so that I can recontour or improve what was done before. Add to it, improve it, or fix what the patient is looking for. A lot of the fat that I remove from other areas that have been previously liposuction is going to come out broken down more because it's encased in scars, surrounded by scars. So areas of fresh fat is really needed. And I'm willing to look at each case individually, and when the patient comes in, I'm willing to talk to you. And also when you're in person in front of me, a lot of times I can examine the patient and feel if the fat that you have had lipoed before, the areas that have been lipoed before, feels fibrotic, and we can maybe not do the inner thighs. And believe you me that a bunch of times where I've not picked the patient for inner thighs and have gone in on a secondary lipo, I regretted it, because patients look great, but the fibrosis or the scarring after a primary lipo does come in the way, and the quality of fat that comes out is not as good as the quality of fat that I get when something is untouched. So that's my reasoning, and I don't think that I've had that much of an issue making somebody look like they have a thin thigh. The one thing about thighs is that you really have to pay attention to the liposuction, to the lymphatic drainage massages after that. They really have to be done consistently, and I think the patient has to get involved themselves. Okay?
Yeah, I'm not getting inner thighs lipo done. So that's it for today, ladies. We'll see you next week again. Please remember to check our websites and our IG page, and DM us if you have any questions in regards to our holidays specials. Thank you.
Happy holidays, everybody. Thank you very much for joining us. Have a good day. Thank you.